You can start. Are you ready?
Yeah.
Okay. Yeah. Good afternoon all. Welcome to weekly webinar organized by College of Physicians Malaysia. We are now in week 1 of our gastroenterology and hepatology month. And our topic for today is gastroesophageal reflux disease. Welcome our speaker, Dr. Liu Ken Guan, gastroenterologist and hepatologist from Hospital Tengku Ampuan Afsan, and our chairperson is Dr. Muhammad Amin, consultant gastroenterologist and hepatology from Pantai Hospital Batu Pahat. Without further ado, let's welcome Dr. Muhammad Amin.
Thanks, Dr. Priscilla, for the kind introduction. Assalamualaikum and a very good evening. It gives me great pleasure to introduce our speaker, Dr. Liu Keng Guan, who will be talking on a very common disease, which is gastroesophageal reflux disease, or better known as GERD. So, about Dr. Liu, he graduated from Laka Manipal Medical College in 2007. He then got his MRCP in 2016 and subsequently did his fellowship in gastroenterology and hepatology from KKM, and also pursued his ESEGH in 2023. He then pursued his international fellowship training in neurogastroenterology and motility at National Taiwan University Hospital. Dr. Liu is currently a consultant gastroenterologist and hepatologist, currently serving in Hospital Tuanku Ampuan Auzan, Kuantan, and he is currently expanding the motility services in Pahang in particular, and also towards the East Coast region. So without further ado, the floor is all yours, Dr. Liu.
Okay, thank you, Dr. Amin. So, good afternoon, everyone. I'm Dr. Liu. Thank you for the organizer to inviting me today. It's truly an honor to be here to present about today's topic about GERD. Is my start? Okay. So now let's begin with the prevalence of GERD disease. So GERD affect about 14.8% of the population worldwide. So it's a main risk factor for Barrett's esophagus. It also can significantly affect patients' quality of life, and also it has steadily increased the cost for healthcare system. So by definition, GERD is the reflux of gastric content into the esophagus, and it can cause symptoms or complications and leading to with the evidence of mucosal injury and also abnormal acid exposure on reflux monitoring. So the main underlying mechanism is poorly function EGJ junctions, which are the LES and also the crural diaphragm. The contributor factor for the GERD symptom includes impaired esophageal clearance, delay in gastric emptying, reduce of salivary productions, esophageal hypersensitivity. So the symptoms of GERD disease are divided into typical and also atypical symptoms. So the typical symptoms are heartburns and regurgitations, which give a high sensitivity and also specificity to the GERD disease. Atypical symptoms include chest pain, hoarseness, chronic cough, globus sensations, belching, or asthma exacerbations. So for our diagnosis, in a patient with classic symptoms but with no alarm features, we usually start patient on 8 weeks of PPI. So if the patient are PPI dependent, or if the response is partial or absent, the next step is we perform OGDS. So ideally, we perform the OGDS with the patient off PPI for 2 to 4 weeks. So the finding like LA grading esophagitis of B, C, D, or Barrett's esophagus more than 3 centimeters are considered diagnostic of GERD disease. So for endoscopy, like I say, the indication is for those who are failed empirical treatment, for those with alarm features, and also besides we use endoscopy to diagnose GERD disease. We also can have look whether there's any evidence of echinacea or complications such as stricture, and also any evidence of laryngopharyngeal reflux. So when performing endoscopy in a suspected GERD cases, I would like to emphasize there's a three very important view. That the first view, which we frequently forgot or neglected. So this is the upper airway, the cryopharyngeal view is very important. And to look for any evidence of LPR, like swelling, any erythema at the upper airway, and also the vocal cord. So next, we go to the distal esophagus, and look for any evidence of um, esophagitis and grade them according to the LA classifications. In reflux view, we can grade the hiatal hernia into its grading. So this is the LA grading of the esophagitis. For LA grade A will be one mucosa break, and which is less than 5 mm and does not extend beyond the mucosa fold. Grade B will be more than one mucosa break, more than 5 mm, and does not extend beyond the mucosa fold. For LA grade C, there will be more than one mucosa break extend between the mucosa fold, but involve less than 75% of the circumference. So the LA grade D will be the most severe type, in which there will be more than one mucosa break, involve more than 75% of the circumference. So now let's look at what's the role of a high-resolution impedance manometry. So HRM is an advanced diagnostic test to evaluate the function of the esophagus. So we usually use a catheter with multiple pressure sensors to insert it along the esophagus, and then it can give our detailed and continuous measurement of the pressure gradient along the esophagus. So by then we can mapping out the esophageal motility. So the indication, besides to diagnose GERD disease, we also can use it to exclude disease such as echinacea, in which is frequently mimic GERD disease. Also, we can also, by doing a manometry, we can look at the gas event, like we can exclude belching, which can cause GERD disease. The other indication is to do it before or post-op assessment, before we going for a surgical interventions, mainly for anti-reflux surgery or procedure, or before or after the POEM, means a oral endoscopic myotomy for treatment of echinacea. So this is a typical setup of a motility lab. So we have a manometry tower at the left-hand side. Patient will be on the center, and there will be an endoscopy system at the right-hand side. So this will help when we have a difficulty in inserting the catheter. So sometimes we can perform the OGDS before we proceed with our manometry. So this is a solid state catheter that we use to insert into the esophagus. It has 36 sensors spaced 1 cm apart, and then you can use to measure the pressure gradient along the esophagus. So this is a 3D topography of the image generated by the manometry. So in 2D, we can look at it is like represented in this way. So there'll be an upper esophageal sphincter, lower esophageal sphincter. There'll be a pressure gradient measuring the esophageal contractions. And here is a more detailed version, and then you can see that the red area is the high pressure area, followed by yellow, green, and then the blue area are the low pressure areas. So from this, the system can let us measure the different parameter of the esophageal motility. So by then, we can use the Chicago classification 4.0 to divide the esophageal disorder into disorder of EGJ outflow and also disorder of peristalsis. For the disorder of EGJ outflow, we have achalasia type 1, 2, 3, and also the EGJ outflow obstructions. For disorder of peristalsis, we have absent contractility, distal esophageal spasm, hypercontractile esophagus, and also the IEL. So these are the two graphic representation of the GERD disease. From the first one, we can see there's an absence of contractility of the esophagus. And we can see the fluid, which are during the swallowing, there will be a reflux back after the swallowing. So for the second, the right lower end, the image show that there's a weak contraction of the esophagus. There will be a swallowing of the fluid. However, we can see there's a little reflux of the fluid after the swallowing. So after we have performed manometry, we can proceed with 24-hour pH monitoring. So this is very useful to evaluate the GERD and also the underlying conditions. So it can detect both the acid and also the non-acid reflux event. So you can more comprehensively, we can assess the reflux pattern compared to the pH monitoring alone. So this is how it looks like. We insert a catheter through the nostril, place it along the esophagus up until the 5 cm above the LES. So patient will carry a device, and we ask the patient to press on the button whenever they have a symptoms, and then we instruct the patient, provide the patient with a diary. So we instruct them to write down their daily activity, whether they are lying supine, sitting, what food they are eating, and when they have the symptoms. So we'll counter check these diaries later on with the tracing. So this is a 24-hour tracing of the pH monitoring. So if we enlarge it and we can look at it, so during a reflux event, there will be a drop of the pH. And then we will see that there's a pattern of reflux pattern going, the reflux going up here, and then subsequently coming down back to the lower esophagus. So for impedance monitoring, mainly it means that there's a gas event. So you can see from here, so this graphic representation is represent the swallowing event. So the system itself can calculate the symptom reflux correlation. So it has a two parameter called symptom index and also the symptom association probability. So SI, if more than 50% is considered positive. SAP more than 95% is considered positive. So we combine all the parameters so we can follow Lyon consensus 2.0. So we can conclude we have a few, based on the parameter, we can have conclusive evidence of pathological reflux, borderline, or supportive. So for conclusive endoscopy evidence of pathological reflux, it must be LA grade B, C, D, or any evidence of Barrett's esophagus or strictures. So for pH or impedance, the patient must have a AET more than acid exposure time more than 6% over 24 hours of studies. So or patient have a AET more than 6%, more than 2 days on a wireless studies. So this is for unproven GERD, means patients, we are not so sure whether they are having GERD. And then we have to off the PVI for 2 to 4 weeks. So for those with a proven GERD, we had known that patient had proven GERD, but then they still have it symptomatic for the GERD disease. So we can put patient on therapy. And then from here, conclusive will be same. Will be LA grading B, C, D, esophagitis, or whether patient has peptic stricture or AT more than 4% and reflux episodes more than 80%. So the difference between the borderline will be the AET between 1 to 4% and the reflux episode about 40 to 80 per day. And the grading will be LA grade A esophagitis. The other parameter is the MMBI that we monitor the impedance, usually at night when patient is lying supine and then patients not swallowing. So this MMBI indicate the mucosa integrity. So for patient with off PPI studies, we look at it. If there's an abnormal reflux burden, we say patient has pathological GERD. If patient have normal reflux burden but have symptom associations, we say patient has reflux hypersensitivity. And patient if they have normal reflux burden and the negative symptom associations, then we say patient has no GERD disease. So we can consider patient whether have functional symptoms or consider an alternate diagnosis. So for those who on medications, if patients have abnormal reflux burden, we should consider if whether patient is having persistent GERD despite PPI, which might need intervention later, or patient have poor adherence to the PPI. Okay, so the other two will be followed same as the medication study. So the management, mainly we are tailored according to the underlying pathology. We must think whether patients, what are the grading of the hiatal hernia, what's the size, what's the grading, how severe is the esophagitis, whether there's evidence of Barrett's esophagus, whether how was the esophageal motility, and whether there's any existing gas event that has causing GERD disease. First and foremost, we must not forget the importance of diet and lifestyle changes. We should advise patients for weight reductions for those who are obese. So we have to advise them to elevate the head of the bed or lying left lateral. If you think the EGJ is uh, um, susceptible for reflux disease, avoid late night meals or bedtime snacks, staying upright after the meal. Also, you have to advise patients to avoid food that can aggravate reflux disease, such as coffee, tea, spicy, acidic food, chocolates, carbonated drinks, and fatty meals. So medication, we have many options. So the first will be our proton pump inhibitor. Proton pump inhibitor is the cornerstone of the treatment. So it provides fast healing and also the heartburn more effectively compared to H2 receptor antagonists. It also can provide symptom relief at 4 weeks. Study have shown that have high symptom relief at 4 weeks in esophagitis compared to NERD. So about the potency of the PPI relative to the omeprazole, it will be start from pantoprazole, followed by Lanzol, omeprazole, esomeprazole, and finally labeprazole. So do remember, we must advise patients to take the medication 30 to 60 minutes before the meal, because we need otherwise it won't be so effective, because we need the activation of the proton pump by meal. So sometimes BD dosing is more superior to daily dosing meal if needed to maintain the pH gastric over 24 hours. So for those with established GERD disease, patient must advise on maintenance therapy. For those who are not, maybe we can consider on-demand therapy or step down to H2 receptor antagonist. Some may worry about the adverse outcome of long-term use of PPI. So a systemic review and meta-analysis has shown that there's a long-term use of PPI associated with many side effects. So, however, bear in mind that this is the observation study. So, which are the observation study which are limited by statistically and clinically heterogeneity, and cannot really establish a direct causal relationship. So next will be the H2 receptor antagonist. We can consider it for additional therapy for persistent nocturnal symptoms, but bear in mind that it may develop tachyphylaxis after a long-term use. So next will be the poor kinetics. Um, uh, poor kinetics may be considered in selected patients as they can enhance the gastric emptying and also improve the esophageal motility. However, their use is limited by its side effects, okay, like metoclopramide, which can cause severe CNS side effects. Domperidone can cause QT prolongations. The most safely used is mosapride. However, it's not widely available. Canaton, sometimes you can use it when with patient with dyspeptic symptoms. Another agent is to mention is baclofen. Baclofen can shown to reduce transient lower esophageal sphincter relaxations and hence reduce the reflux episodes. However, its use also limited by the side effect of giddiness, somnolence, and constipation. Sucralfate is another option that works by forming a protective barrier over the mucosa. However, it's not routinely used in GERD disease. For me, personally, I've never used sucralfate before. Alginate, in daily practice, we commonly prescribe alginate, which provide rapid symptom relief, and in some cases, it can serve as a bridging therapy while awaiting for further investigations, like endoscopy or manometry surveillance. So now moving on to the endoscopy anti-reflux therapy. So for this therapy, we must exclude big GEJ defect in which like hiatal hernia more than 2 centimeters, GERD, severe GERD grading of a C and D, case in where patient has esophageal stricture and a long segment of Barrett's esophagus. So there are few options available here. So now let's look at the strata. What strata? Strata is a technique that utilizes the radio frequency energy to induce swelling and then cause fibrosis at the GOJ junction with the aim of reduce the reflux episodes. So study have shown that it can significantly reduce the esophageal acid exposure, improve the quality of life, and also to reduce the PPI usage. However, the energy is delivered is inconsistent and highly variable. So for the time being, it cannot recommend as is used as an alternative to medical or surgical anti-reflux therapy. So this is a video of how Strata works. So we use the medical device, and then it employs the radio frequency energy at the lower esophageal sphincter, LES. So induce the swelling at multiple points near the LES. Sorry. So subsequently, it causes a swelling, and yeah, that's how it works. So now let's look at the teeth, transoral incisional fundoplication. In this one, they create a flat valve along the fundus. So it like suturing around 180 to 270 degree to create a tight lower EGJ opening to prevent the reflux. So this has a low risk of perforation and bleeding and improve the acid exposure after the teeth procedures. So I must mention about the arms procedure. This is anti-reflux mucotectomy. So it was first introduced in 2014 by Prof. Inoue. It was actually discovered incidentally during for a patient who are undergoing EST for Barrett's esophagus with high-grade dysphagia. So the principle is to resect the gastric mucosa at the cardia, and then subsequently it heals with a scar formation and subsequently causing the narrowing of the lower EGJ opening. So we have shown that it can actually improve the acid exposure, emission score, the flat valve grading, and also the acid, even the bowel and so the acid exposure. So for ARMA is the improved version of the arms. Instead of the mucosal resection, ARMA used the APC to apply along the gastric cardia in a butterfly shape. And then when it heals, it causes fibrosis and tightens the lower EGJ junctions. So this is a simplified version of the arms and has reduced the risk of perforation and can be used to retreatment of the patient who have failed arms and can be repeat for a few times. And the good thing is this procedure does not require a specific expensive device like strata and teeth. So for patient selection, for this procedure, it will be hiatal hernia size less than 3 centimeter, flat valve grading less than 3, and there's a must be absence of significant sliding hiatal hernia, and there will be low risk of stenosis based on study, and it has shown to improve the GERD score, the functional score, and also the emission score and acid exposure. Lastly, we come to the surgical management, which is considered in patients who not suitable for endoscopic approach. So it have proven to have been about 80% chance of long-term freedom from PPI, but it carries about 4% risk of acute complications and about 17% of risk of GERD recurrence. So the type will be fundoplication, whether it's complete or partial. Gastric bypass is mainly for those with obese. The common approach nowadays is laparoscopic. It's less invasive, but still it carries a risk of periportal morbidity, dysphagia, gas protein, and also a considerably need for routine intervention. Okay, so now we come to a case study. So this is a 70-year-old lady with a background history of mixed CTD with a lung fibrosis, with a refractory symptom despite compliant to the PPI. She complained of heartburn, neck pain, epigastric pain. So we reviewed her OGDS done in 2021, and we found that patient, it was documented that patient has hiatus hernia, and there's no evidence of GERD. So supposedly we should repeat an OGDS for this patient. However, it's not done here. So this is the manometry pictures of the patient. So what do you think? Yes, this is a case of absent contractility because there's no contraction of the esophagus. As you can see from the swallowing itself, the water already pulling up to mid-esophagus. So we proceed with the pH monitoring. So this is the report. And I would like to show you that during the event, this is the event, and patient press on when they have the symptom, they press on the button. And this is the line showing that this is where the event occurs. So during the event, we do not see any changes of the impedance monitoring. So there's no reflux, nothing, no drop of pH. So the report, this is the report of the pH monitoring. There will be 3.7% of the acid exposure time, mainly occurs when patient in supine positions. The Demeter score is abnormal, and patient symptom association is SI is 0% and SAP is 0%. So there's no symptom associations. So this is a case of pathological reflux with negative symptom association. So how do you think these patients should be managed? Okay. So for this patient, at first, we have to advise patient regarding the lifestyle modifications, about the food, what's the positioning, emphasize on when's the meal time, avoid late night meal. Also, we have to optimize the GERD therapy because patient has pathological GERD. So optimize the PPI. Maybe you might need to consider add-on arginate or prokinetics, mainly at night times. Also, we have to explore the mood disorder, whether we need to consider neuromodulator, whether we need to refer the patient to psychiatry evaluation. And finally, do you think patient need endoscopy or surgical interventions? So for these patients, endoscopy or surgical intervention, I think, is not suitable because there's an absence of contractility. And if you undergo the endoscopy or surgical intervention, patient might develop dysphagia later on. So for case study 2, this is a 48-year-old lady with no known medical illness, with refractory GERD symptoms despite optimal medical therapy. So we repeat our OGDS for these patients. So from the clinical view, it's quite normal, no swelling, nothing, and no erythema. And then the distal esophagus, no obvious esophagitis. Maybe there will be a slightly break in the check line. Reverse view, you might see a huge flat valve of grading 2, 3. So her manometry showing a normal contractility. For all PPI pH monitoring during her event, you can see the chest pain. She was complaining of chest pain. And during the event, nothing actually happened. You can see the impedance, it was flat. So the reporting of these patients, there will be 0% of SA exposure time. The Dimiger score was normal. There'll be the only 8 reflux episodes, which is 2 was acidic and 6 was non-acidic. And then the symptom association was 0%. And her MMBI was normal, indicate normal mucosa integrity. So for the diagnosis of these patients, is there a pathological reflux? No evidence of pathological reflux. What about the symptom associations? Negative. So for this patient, so mucosa integrity is preserved. So we can say patient has functional chest pain. So how do we manage for these patients? Okay, so first, because patient complaining of chest pain, we must consider whether patient really has some cardiac abnormality. So patient might need to refer for cardiac evaluations. And patient has also we have to explore whether patient has this mood disorder. Okay, so if there is, maybe you can consider to refer for psychiatry assessment. The next will be the medications. Since patients do not have a real pathological reflux, we might consider PRN or even step down of therapy. So sometimes we might consider neuromodulator in these kind of patients. Okay, so in conclusion, PPI is and lifestyle modification remains the cornerstone of the drug management. Advanced motility testing can provide extra valuable insights in refractory GERD disease and guide the personalized therapy. So endoscopic anti-reflux mucosa interventions offer a promising minimal invasive option for patients with persistent symptoms. And surgical intervention is reserved as the last resort for patients with a significant anatomical or barrier defect. So with all this, a patient-centered stepwise approach can ensure optimal symptom control and improve the quality of life and reduce the disease burden. Okay, with that, I thank you.
Thank you, Dr. Liu, for the insightful presentation on gastroesophageal reflux disease or GERD. So I think Dr. Liu will be happy to take any questions. So there's a question for Dr. Liu. Which PPI is more superior between Pento and S-omeprazole? And how much is the maximum dosage that can be given and the frequency for PPI?
For PPI, obviously the esomeprazole is superior compared to pantoprazole. If you compare to the, like I said just now, consider omeprazole equivalent. And for the dosing for the PPI, we can give BD dosing if patient needed for the breakthrough at night, especially symptom at night. But then we must always remember to inform the patient that they must take it with empty stomach 30 to 60 minutes before the meal for optimal effect.
So I hope that Dr. Liu answers the question. Any other questions? You can always put in the chat box, in the Q&A box. So basically, you can ask any questions there, and Dr. Liu will be happy to answer it. So any other questions for Dr. Liu? So I got a question for Dr. Liu. Have you started doing anti-reflux endoscopic therapy in Kuantan, Dr. Liu?
I remember last time we have done it once in HKL. I'm not so sure whether you joined us before this.
With Dr. Giu.
Yeah. So we have potential patients. So we still looking for potential patients. I think we have two currently, and then waiting for the manometry assessment. So maybe we can consider to proceed the anti-reflux procedure endoscopy coming soon. Yeah.
Good to hear.
So for those who are resides in East Coast and near to Kuantan, if you have a patient who are having these refractory symptoms and they have resource like they can make the payment or they have insurance, you can actually refer to our center. Yeah. So we can collaborate with the vendor so we can proceed with the assessment. So maybe we can do something more for the symptoms.
So Dr. Liu, there's another question. Does belching and regurgitation necessitate in GERD diagnosis?
Yes.
Because sometimes patient denies water brush sensation.
Yes. Belching is very important assessment. Do remember to ask whether patient has belching disorder. There we have some patient that have uncontrolled non-stop belching during the throughout the days. It actually study have shown that it actually in some patients it actually this is the main cause of their reflux disease. So if we detected the belching disorder, this is causing the GERD disease, we can actually target the belching disorder and then treat it. So many has improved after we give them the treatment of the belching disorder. We can identify it based on the history itself. but more objectively, we can assess based on our pH. Sometimes you can see from the manometry, and we can more objectively assess by using the impedance, 24-hour impedance monitoring.
Any other questions from the floor for Dr. Liu? Another question for Dr. Liu. How does endoscopic and surgical intervention can cause dysphagia if done for patient with severe GERD?
Because the esophagus, if done in patient with
Severe GERD.
severe GERD, how it can cause dysphagia? Because sometimes you, by endoscopy or surgical interventions, you are wrapping up the lower esophageal junctions opening. So sometimes it might be too tight to wrap it up. So it causes dysphagia for the patients. For endoscopic procedure, we are more flexible because we can, in some patients who are having dysphagia after the AMA or ARMS procedure, we can use the balloon dilatation to dilate a bit, so to improve their symptoms. For surgical intervention, I think a bit difficult because it's a surgical wrap. So before the procedure, usually we'll do a manometry to look at the esophageal reserve. So if the esophageal reserve is there, so they'll be less likely to have dysphagia. So maybe you can go for a complete fundal plications. If the esophageal reserve was not there, so maybe you might need to consider for partial fundal plications. So that's why whenever you want to go for any this procedure, you must first have manometry evaluations before you proceed with the procedure.
Thank you, Dr. Liu. So there's another question. What is the best treatment for patients with dyspepsia and bloating?
Dyspepsia is a broad term, so you need to assess properly what do you mean by dyspepsia. Are you having abdominal pain? So it's a big topic. I think this topic will belong to Dr. Hari next week. Okay. So I think most importantly, you must talk to the patient, get a detailed history. What do you mean by what's the main symptoms? Was it bloating? Was it abdominal pain? Take a detailed history. What are you currently taking? What's your diet history? Okay. What have you tried before? Whether it's relief or not. Sometimes you might need to ask, how's your bowel opening? Are you constipated? And there's many causes. Yeah. So sometimes we have to, when you have no clue, where you have to exclude with endoscopy assessments, and then you have to do some other tests, many tests that we can be run for this kind of patients. So this is a wide topic. I let Dr. Hari to explain to you next week.
There's another question. Is it recommended to give PPI along with H2 antagonist in GERD? If so, what type of H2 antagonist?
I've seen people use PPI along with the ranitidine for their use. The ranitidine mainly used for those with nocturnal breakthrough symptoms. Why? Because we use PPI, we need patient to have must take it before 30, or I always emphasize you must take it 30 to 60 minutes before the meal. So you take it and then wait for some time. You take your meal, so activate your proton pump. Then the PPI can go and bind it. So we advise patient do not take food before late before you go to bed. So with empty stomach, you can consider the H2 receptor antagonist. So this is why we use H2 receptor antagonist during the bedtime. So usually, I don't know, last time we have a ranitidine. So see what's available at the center.
Generally, I think ranitidine has been pulled out from
Yeah.
the market.
Yeah, last time. But bear in mind that actually ranitidine, after a long time use, it develop tachyphylaxis. Yeah.
Does PPI plus domperidone help in gastritis or GERD?
Why we need to consider poor kinetics? Because sometimes you might think that you suspect patient have delayed gastric emptying. So you help you with the gastric emptying. However, to use domperidone, we always get scared by their side effects. Nexolon, we have that we worry about the tendinitis dyskinesia. Domperidone long-term use can cause QT prolongations. So sometimes you can consider in those you suspect they have delayed gastric emptying, or they like to take the late night meal. You might think this can be help them. So safer option, I've seen mosapride, but then I checked my center, we do not have mosapride. What we have etopride, Ganaton. Some patient I will give them Ganaton, maybe at night.
Basically to improve gastric emptying, right?
Yeah.
Can GERD cause PVC?
PVC.
When
Heart.
heart.
Heart problem, no.
Yeah, generally
Not
no.
that I know of.
So any other questions for Dr. Liu from the floor? If not, I think we shall end here. Is it okay, Dr. Tisila?
Yeah, doctor. I think there's no more questions, so we can end here.
Okay.
Thank you, Dr. Liu, for this very comprised talk, and thank you, Dr. Amin, for chairing this session. I will see another week for a more interesting talk. Thank you.
Okay, sure. Thank you. Thanks, everyone. Thanks, Liu.